I recognize some of you from the training that we've done before, and I may have met you in other contexts. So it's lovely to have you with us again today. It might be a bit of a refresher for some of you, as well as some new material for those who haven't met us before. So just to run through what is on our Conflict Cafe menu today. We're going to start by talking a little bit about what do we mean by conflict in the context of paediatric healthcare, and thinking about why recognizing and managing it matters. Going to talk a little bit about mediation too, and the sort of cases in which it can help, and end by mentioning our new MMF framework for managing conflict as a team, which is where our current focus is at the moment. So I'd like to start with a quote which we often use in our training, and which seems really relevant to the territory that I'm going to be talking about today. It comes from an American writer and surgeon called Atul Gawande, and from his book Being Mortal. And he says, "I'm in a profession which has succeeded because of its ability to fix. If your problem is fixable, we know just what to do, but if it's not..." And the reason we use this is because so many health professionals have told us that they feel more comfortable when they're in the territory of being able to offer information, to come up with solutions, to make things better, to give parents information, but much less in their comfort zone when the agenda isn't theirs, if you like, when there is a lot of high, complicated emotion which they don't necessarily understand the causes of. And conflict takes us into this territory, and we hope with our training, and perhaps by the end of today, you might feel a little bit more comfortable in stepping out of your comfort zone and being able to acknowledge, name, to recognize those conflicts, which we know are distressing and upsetting for everybody. So how do we define conflict in the healthcare context? We started our work at the Evelina Children's Hospital back in 2013 with my colleague Essie Menson, who is with us today. And we started by asking health professionals what they meant by conflict. How would they define it? It's not a word which many health professionals like very much, because it feels rather frightening, and most of us probably are conflict avoiders. But these were the three factors that emerged in a survey we did of just over 200 health professionals, when we asked them, what are the key factors you would need to see to identify something as a conflict? So it was the breakdown in trust and communication, between the professionals and the child or the family members, which tends to draw everybody in and has an impact on everybody. Secondly, and really important, that it can have an impact on the ability of the treating team to provide the care that they believe is best for the child. And we put best in inverted commas because we've seen that where there's agreement between professionals and families, use of the words best interests doesn't tend to trigger conflict, but where there is tension and disagreement, using that word can very often trigger further anxiety and upset for the family because it sets them up in opposition. We know what's best, they will tell us, and the professionals with all of their experience will say, but we know what's best. So it's a word we tend to try and avoid using where there's conflict. And the third factor was that breakdown in trust and communication, which can affect staff morale. And we often see staff asking not to look after a particular child, not usually because of context with the child, but because of the conflict with the family. What are the most commonly cited causes? And we did a piece of research again at the Evelina in 2013-14, tracking conflict cases over the same 2 months, three months in a 2-year period. And these were the top 4 causes: a communication breakdown, disagreements over treatment, families feeling they need to micromanage care and treatment. And we think about the reasons for that in the training that we do. And unrealistic demands and expectations. So it's really important to emphasize that we're talking about health professionals cited causes here. And we thought we probably only got the tip of the iceberg in those 136 episodes, but look at the amount of time it took to manage, and we start to see the real impact of conflict. So let's hear from some health professionals, quotes which come from them directly, and as you'll see in a moment, from a family member as well. This is from a consultant pediatrician who says, I feel very sad when I find myself in those situations. I feel like somehow I have failed as a doctor, which is a very powerful, upsetting thing for any consultant to say. But we were talking about the impact of conflict and where it could take them. Then we heard from a nurse and who says it can mean the child suffers. It doesn't become about the child anymore. It's all about the conflict and winning these little battles about the small things. Each decision, the child's lying there in the bed and it feels a little bit like they've been forgotten. So we start to see the impact of conflict on the person who matters most to everybody, the child. And our third quote is from a mother. When there's no compassion, she says, when there's no communication, when there's no empathy, when all these things are removed, what you see is a gap. What you see is a massive barrier. And when that barrier is there, nobody tends to listen to each other. It's all about war, war. Now, war in this context, I appreciate, may feel like an unacceptable word to some of you, but I think from our experience, what we have seen and what we've heard from families and professionals over the years leads us to feel that it is very much an emotional war zone, which conflict in this context can take families and professionals alike into. So it was striking to hear this mother use that word so specifically. I wanted to just show you briefly the conflict pathway that we have developed from a piece of research we did right back at the beginning when we were starting this work in 2010. And I interviewed with a colleague just under 50 professionals and parents, ethicists, lawyers, hospital chaplains who'd had direct experience of conflict of one degree or another. And we started to unpick and ask the question, are there triggers which we can identify? Are there clear behaviors? And crucially, does conflict escalate in a predictable way? And when those interviews were analysed, there was quite a clear pattern that emerged. And we've turned it into a traffic light pathway to prompt, to prompt early recognition, if you like, to put a shape around conflict so that we hope that it comes to be recognized as a phenomenon that can be recognized and tracked. The symptoms of it can be recognized rather like you'd recognize and treat the symptoms of a disease. So thinking about conflict as a phenomenon which exists and which needs to be recognized and managed rather than run away from, which I know for so many of us that is our instinct when conflict arises. So we've got our three zones here, the green zone, amber zone and the red zone. And you'll see in each of those zones, the things that we have picked out as being key. So language, really critical for causes and triggers, and also making assumptions. We hear very often parents being described as difficult parents, whereas we try and reframe that a little bit and talk about difficult situations, while not being naive about the fact that we know that in some cases families' behaviours can be extraordinarily challenging and upsetting. We need to think about how to manage those in a different way. And in our amber zone, where we've got our little elephant, we're seeing some really clear behaviours and warning signs as conflict starts to escalate. And the reason we've got this little elephant in the corner is because we've seen that so often people know that there's something not quite right. They know that communication is becoming tense, but there's a fear about acknowledging and naming it. And I think we've seen from experience now that the sooner it is acknowledged and named, the quicker people can get on, health professionals get on and think about how to manage it. Conflict tends not to de-escalate all by itself, which is why in this middle zone, it's becoming so important to actually to manage it and to identify it. Because we don't want to end up in the red zone where, as I think that mother intimated, the child gets lost in the middle. The child, if you like, becomes the victim of the conflict because it takes on a bit of a life of its own. And we know at its extreme end that it also can involve physical and verbal threats or attack. And we always make a distinction. We know that professionals have their own thresholds for when it would be appropriate to call for help. And we absolutely know that. And it will be different for professionals working in the hospital setting and professionals working in the community as well, where those thresholds for safety may feel lower. So we know that all of this stuff is complex. Modern medicine becomes ever more complex and the choices are huge. So it's inevitable that there will be disagreements. But I think the critical thing we'd want to emphasize is that disagreements don't have to become conflicts. Of course, parents and families will challenge, will disagree with the decision-making of health professionals, but it's how those disagreements are managed that makes all the difference. And one of the ways that we try to look at this is to think about not right and wrong in conflict, but about different perspectives, about acknowledging different perspectives on all sides. So, for example, we know with medical advances that the question that so many professionals ask themselves all the time is, just because we can do this, should we do it? It's one of the biggest ethical questions we discuss. But from the parents' perspective, they will often be thinking, you know, can we trust them when they tell us they've done everything? And those perspectives are working together. They can work together, but what is it that sometimes tips them over and changes that conversation into something that becomes conflict? And I think the question we ask is, what is it that makes the difference? And for so much of our work, it is about communication. The one thing which we hear almost every family say to us is, well, they're just not listening to me. And the one thing that we often hear professionals say is, well, you know, we've explained that, we've told them that, but they haven't been able to hear it. They haven't heard us, they haven't listened. So we're starting from a place where there is not enough listening, there's not enough shared communication going on. And that is often the point which escalates us into conflict. So the training that we do is very much focused on unpicking the key skills that are needed to help engage with parents when conflict arises, but also de-escalate. And those are skills that most of you will be very, very familiar with, I imagine, in your training. And they're very transferable. They haven't perhaps necessarily been thought about in the context of conflict, though. So we focus on that, on understanding and early identification of conflict and how to step into the shoes of families and patients. And we do that with care, because it isn't possible, of course, to literally step into the shoes of somebody else, but it is possible to get alongside a family when they're in conflict and when conflict arises, and to listen in a different way, which we spend a lot of time talking about in the training. And we call that listening. We listen for emotions as well as for information. We've heard a number of doctors say how their training is often focused on listening for facts, listening for information, listening for those important clinical details. What our training focuses on is how to listen for all of those, but crucially how to listen for what lies beneath those facts and information. And it's often that which helps to really build that trust and connection and to de-escalate conflict when it arises. So what happens with all that stuff? You've tried it all and it doesn't work. So there is another option to consider, and that is the other part of our work, and it's mediation. And you might remember from the Charlie Gard case back in 2017 that in his first judgment in Gard, Justice Francis said, "It's my clear view that mediation should be attempted in all cases such as this one, even if all that it does is achieve a greater understanding by the parties of each other's positions." So that was a really key pointer, if you like, from the judiciary, that they wanted to see mediation used in more of these cases. So what is it? For those who don't know anything about mediation, I often say when people say, well, what do you do as a mediator? And actually, one of the really key things that we do is we help facilitate conversations which might not otherwise be able to take place, because conflict has arisen to an extent that the parties involved find it almost impossible to be in the same space, to communicate with each other in a way which doesn't escalate into conflict. So mediation is really a process of supporting people in conflict to be able to understand and hear each other's positions and to find a solution that's acceptable to all. Now, of course, in many of the mediation cases we get involved in, they are cases involving withdrawal of life-sustaining treatment. There are never going to be happy endings in these cases. So we don't use, I find it success in mediation is not a word I use very often, because we know that those happy endings are not there. But what we can help professionals and parents to do is to talk about the decision that has to be made in a different way, and hopefully to find a solution which is acceptable, even though it may not be that happy ending, which of course doesn't exist very often in the sort of cases that we're dealing with. Mediators are impartial, so we don't take sides, and that is really important. And neither do we decide or arbitrate. Our role is to support those conversations and to support the parties to try and arrive at their decision, which is going to work for them. And then we help them reality test it and write it down if that's what they wish to do, and share it with others if that's what they wish to do. And the final point is the mediation is voluntary, it's confidential, and it's legally privileged. Those three things are absolutely critical. Nobody has to mediate. There is a debate going on at the moment as to whether mediation should be compulsory in some cases, and there are very, very strong views on both sides of that argument. So what are the sorts of cases where medical mediation can help? Obviously, from what I've been talking about, where there's disagreement, where there is families and professionals can't agree about treatment and care. Also in the Court of Protection, we mediate cases where there is disagreement about the care or treatment of a young person or adult without capacity. When communication has broken down, positions have become really entrenched. When parties feel, for whatever reason, that their voices are not being listened to, and not being acknowledged, understood, and respected. And of course, as an alternative to making an application to court, but it's important to say that mediation can run alongside the court process as well, because what the court is talking about can be very, very different from what we talk about in mediation. The court isn't interested really in discussing the way that the parents and professionals communicate with each other. They are interested, and that is their role, in deciding what is in the best interests of the child. Mediation is involved in a whole other territory. So the two processes can be very valuable working alongside each other. And what are the benefits of mediation? Well, that's not for us to say. It's really for those who've been involved in mediation to tell us, I think, and reflect. So this is what a nurse who'd been involved in one of our cases said. It absolutely changed how we felt. It made me realize that this is a set of parents that are absolutely desperately wanting the best for their baby. And it made us think, it made us reflect and see where communication could have been much, much better. And a parent told us we felt that was the first time with ourselves as parents and the medical teams that we sat down and they listened to us and understood us for the first time. We were able to make the right decisions. We were able to work together. I wanted to finish by just briefly talking about the next, or where our work has currently taken us to, which is to think about how we manage conflict within a clinical team. And we've developed and piloted and published in the BMJ recently on the outcomes of that pilot, a framework which really covers the whole spectrum of recognizing and managing conflict, from the the listening, the communication that we've been talking about at one end, right through to a more formal process if conflict has escalated, and all of those skills which we talk about in our training have not worked for whatever reason. Conflict has escalated. There are more difficult behaviours which need to be managed. We want to see this process as a spectrum rather than, as in quite a number of places, what we've seen is that there is only the part two, there's only the punitive bit called a behaviour contract or something similar. There isn't the first bit, which takes us to a place of really being able to understand where this stuff comes from in the first place, which feels really important if we're going to manage it compassionately as well as constructively and collaboratively with families. So just to end on a few of what we've called the top tips, which I hope are useful and might resonate. We say, don't be afraid to talk. Don't avoid the people or the issues, hoping they will go away, because they usually don't. Phone calls between admin staff or anybody who is talking to a parent can quickly escalate into conflict if the person having that call is not trained in managing difficult or challenging conversations. So that's why we train right through from admin staff, ward staff, right through to the most senior consultants, because those skills need to be shared really between all members of a healthcare team. Listening is key. Most people just want to be heard. And we talk about trying to avoid saying, oh, there's nothing to worry about, but actually asking, what is it you're worried about? Because that will tell you. We don't need to make assumptions. If we ask, we'll find out what that story is, which is why we say be curious. And it's what we do in mediation. We teach our mediators to be curious. Being curious will take us a long way in being able to ask the sorts of questions that will tell us what's going on beneath that exterior, beneath some of those really challenging emotions that we might see. And we try and avoid saying difficult patient, difficult parent, and instead think about it as a difficult situation, reframe it so that we're not judging the person, we're dealing with the situation that they find themselves in and which may have provoked the behavior that you might be finding really challenging. So that trying to put yourself in their shoes is an important part of that process. And we think about apologies. We don't spend a lot of time talking about them, but one of the things we quite often hear people say is, I'm sorry you feel that. Whereas actually what lands more effectively is often, I'm sorry that what's happened has made you feel this. And that is not taking liability or accepting blame. It is just acknowledging that what that person has said they're feeling is what they're feeling, and that's what we need to be working with. One of my colleagues had this lovely phrase, explore before you explain, and that rather takes us back to the first quote from Atul Gawande, move away from the fixing and telling and into the exploring and being curious. And the last point here sort of sounds obvious, but when conflict arises, because our response to conflict is that fight or flight mode, we put the barriers up, we put our armor on. What we're suggesting is that you try hard to take that armor off and to engage on a human level, because that is often what de-escalates conflict and builds connection between professionals and families, and can do the trick in ways that might be difficult to imagine sometimes, but we have seen it happen. So, now I did have I wonder where it's gone. Here it is. The what next? Before we open it up for questions, we just wanted to let you know that our first online module is just starting its initial round of testing, and that our next Conflict Cafe is on June the 28th, and we will be presented by our associate Claire Sieber, Dr. Claire Sieber, who's a GP and a mediator, and she's going to be talking about and challenging some of the myths about mediation in healthcare. So you can book that on our website. If you'd like to know more about the e-learning, then get in touch with Simon, who introduced me at the beginning, and he can tell you more. So I am going to